Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Kimberly Miller. In today's episode, we will review the burden of RSV disease in older adults and discuss the latest updates on RSV vaccination recommendations and safety data. I'm joined by Dr. Carolyn Bridges, consulting physician and director of adult immunizations at immunize.org in St. Paul, Minnesota. This episode is part of a larger educational program titled Removing Roadblocks: Practical Approaches to Increase Adult RSV Vaccine Uptake. For more information on Dr. Bridges, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started.
To start off our session on RSV vaccination, we're going to start by talking about some issues about burden of disease and some other background information on RSV. So the burden of disease for RSV is substantial. This summarizes some of the data from a systematic review and meta-analysis on hospitalization, emergency department visits, and outpatient visits with RSV. The ranges for hospitalization are 178 to 267. Hospitalizations per 100,000 persons. These higher estimates estimate the rates that would be using a more sensitive test like a PCR. For emergency department admissions, they're from 133 to 200. Emergency admissions in adults 65 years and older per 100,000 per year. And for outpatient visits, from 1,500 to almost 2,300 outpatient visits per year per 100,000 adults aged 65 and older. Given the burden of disease, there have been multiple attempts to make RSV vaccines. Previous attempts have encountered some difficulties in designing a stable target. However, there was breakthrough in vaccine development through the targeting of the pre-fusion version of the F-glycoprotein. So by stabilizing the F-glycoprotein is to pre-fusion state, that really has helped in terms of having the body generate neutralizing antibody that's effective in preventing RSV. The F-glycoprotein is a major antigen for RSV. It's responsible for viral fusion and host cell entry. It elicits a neutralizing antibody, particularly in its pre-F form, and this antigen is highly conserved across RSV subtypes A and B. There are currently 3 FDA-approved RSV vaccines. Just to point out that the FDA indications can differ from the CDC recommendations in terms of who CDC recommends for vaccination. So there are 3 vaccines. The RSV pre-F, this is a bivalent vaccine. It's given IM. It's a recombinant vaccine. Its indications are for adults 60 and older and pregnant people 32 to 36 weeks gestation. And more recent indication is adults 18 to 59 years of age, increased risk of lower respiratory tract disease caused by RSV. The RSV pre-F3 adjuvanted vaccine is also a single-dose recombinant vaccine, also is indicated for adults 60 and older, as well as has a more recent indication for adults 50 to 59 years of age at increased risk of lower respiratory tract disease. There is also an mRNA 1345 vaccine. I'll just refer to that as the mRNA RSV vaccine, also a single dose, and it is indicated for adults 60 and older, and that was FDA approved in May of 2024. So in the phase 2-3 initial clinical trials for all 3 of these vaccines, they use slightly different definitions. But if you look at the lower respiratory tract disease outcomes against laboratory confirmed RSV, the efficacy estimates are relatively comparable with overlapping confidence intervals for these 3 vaccines. So in general, around 80% effective at preventing lower respiratory tract disease caused by laboratory confirmed RSV. In terms of serious adverse events noted in these phase 2-3 clinical trials, they were comparable between the vaccine and the placebo. In terms of numerical differences noted in the clinical trials, there was a numerical difference in terms of reported atrial fibrillation events for the RSV pre-F and RSV pre-F3 adjuvanted vaccine. Both of those vaccines, there were 10 events in the intervention arm versus 4 events in the control arm. Subsequent to these initial clinical trials, there was found in a population study to be no difference and the increased risk of atrial fibrillation after RSV versus after influenza and Tdap. Post-authorization safety studies are still ongoing. And just to note that routinely for all vaccines, both CDC and FDA routinely conduct vaccine safety surveillance. And so that vaccine surveillance is ongoing and is reported at publicly available ACIP meetings. So you can find that information on the ACIP website and at public ACIP meetings. So what about Guillain-Barré syndrome? So in these phase 2-3 clinical trials with the RSV pre-F and the RSV F3 adjuvanted vaccine, there were 2 GBS cases within 42 days of vaccination in the RSV pre-F and 1 in the RSV F3 adjuvanted, none in the mRNA trial. Subsequent to those initial trials and after licensure, they looked at the vaccine adverse events reporting system and estimated that the excess rate was approximately 4 million cases of GBS after RSV pre-F and 1.8 cases after RSV pre-F3 adjuvanted vaccine. Based on these additional analyses, the FDA added a warning for GBS to both the RSV pre and RSV pre-F3 vaccine labels that GBS may occur in the 42 days after vaccination. However, at the subsequent ACIP meeting where they reviewed this data, they concluded that the vaccine benefits and the risk of severe RSV disease outweighed the rare risk of GBS.
So what are the current ACIP recommendations? Just in mid-April of this year, the ACIP met and they updated a recommendation. So prior to April, the recommendation was for all adults age 75 and older and adults 60 to 74 at increased risk of severe RSV were recommended for RSV vaccination. Based on the data presented and the discussion of burden of disease and vaccine safety and other indications, the ACIP voted to lower that age from 60 down to 50. So now the recommended age group for risk-based RSV vaccination is now 50 to 74 instead of 60 to 74. Shared clinical decision-making is no longer included in any of the RSV vaccine recommendations for older adults. I will point out, however, that usually in the past, after the ACIP has made a recommendation, the CDC recommendation and sign-up follows generally very quickly within a few days. However, right now we have not yet seen that CDC sign off on this recommendation. Once CDC does sign, then the clock starts in terms of the requirements for insurance coverage for a new recommendation. So we are waiting to see exactly on which date we see that recommendation coming from CDC based on the ACIP recommendation. I will also just point out that the single-dose RSV pre-F vaccine is also recommended, continues to be recommended during pregnancy, during gestational weeks 22 to 23, during September through January, to decrease the risk of RSV disease in infants. So that recommendation has not changed. So what about the timing of RSV vaccination? The ACIP, again, recommends that RSV vaccination may be given at any time during the year. However, their clinical guidance notes that RSV vaccination may have the most benefit if given in the late summer or early fall. It should only be given to adults who have not yet received a dose of RSV vaccine, and it is not an annual vaccine. So currently the indication is for only one dose.
So in terms of the seasonality, generally is October through April. That's why the recommendation for early fall or late summer is recommended. We did have the seasonality for RSV and many other respiratory viruses interrupted during the pandemic, but it appears that we have now returned to our pre-pandemic patterns. So let's switch and talk about some of the risk factors for severe RSV disease. It's most pertinent for those people who are 60 to 74 years. This is also from the CDC website, showing factors associated with severe disease. That includes chronic lung disease, cardiovascular disease. Notably, this excludes isolated hypertension. So if your only risk factor is hypertension, that is not an indication for RSV vaccination. Immunocompromise, however, is an indication, as are hematologic conditions like thalassemia, sickle cell, certain neurologic or neuromuscular conditions, particularly those that would result in someone having difficulty with clearing their airway. Diabetes with end organ damage is another indication, as is liver or advanced chronic kidney disease, severe obesity, or having a patient that lives in a nursing home or a long-term care facility or who the clinician determines to be frail. So of all those risk factors for RSV, the most prominent one, of course, is age. So older age is a significant and key risk factor for RSV-associated hospitalization. Consistently across years, it's older adults who have the greatest risk of hospitalization. More recently, the 2022-23 RSV season, there was an estimated 107,000 hospitalizations and almost 6,000 deaths among people 60 years of age and older. In terms of vaccine uptake, so the first season in which vaccine was available was the 2023-24 season. So toward the end of the summer, we had around 20% or so people who were eligible who had received RSV vaccine. Now we're at about just under 40% for high-risk 60 to 74-year-olds and about 45% for people 75 and older. Importantly, a CDC report also noted that overall, it's about 80% of patients so far that have said, hey, I really would like to get RSV vaccine, or I'm interested in getting it. So we certainly have a long way to go to help those people and offer RSV vaccination who have not yet been vaccinated.
Thank you, Dr. Bridges. And many thanks to you, our listeners, for joining us.